Thank you for joining us for DMTs for MS, Initiation, Monitoring, and Rationale for Treatment Change. This activity is supported by independent educational grants from EMD Serono, TG Therapeutics, and the Catherine C. Moore Foundation. Before we begin, I would like to bring to your attention the target audience and accreditation information. I would also like to let you know about the credit designation, as well as let you know that you will receive an email from education@mscare.org tomorrow with instructions on how to claim credit for this activity. Finally, I would like to let you know that the faculty reported the following financial relationships. It is my pleasure to introduce Dr. Leora Freeman. Dr. Freeman is the medical director of the MS and Neuroimmunology Center at the Dell Medical School at the University of Texas at Austin. Now, I would like to turn the meeting over to Dr. Freeman.
Such a pleasure to be with you all tonight. Thank you for showing up in the evening to learn more about DMTs. I have the great pleasure to be joined by two wonderful women and friends, and that are going to give us a great talk today. So Dr. Diana Endino is a neurologist and lead of the MS and Neuroimmunology at Austin Regional Clinic. And Dr. Lauren Tardo is the clinical lead of Neuroimmunology and MS Clinic at UT Southwestern Medical Center. Today, we are going to learn about DMTs. We're going to learn to differentiate high efficacy and moderate efficacy MS DMTs in order to better select therapies that address disease characteristics and patient preference as initial treatment, and if a treatment change is needed. We will also describe how to use shared decision-making for MS-DMT decisions with our patients. And then finally, we will explain the factors that can indicate a need for a change in DMT and focus in particular on safety monitoring. Next slide. And with this, I would like to give the mic to Dr. Diana Endino.
Good evening, everyone. Thank you, Laura, for the kind introduction. I think it's important if we start back with a little bit of history of how MS, looking back, dates back to the 14th century. So it's something that we have known for a very long time. And it wasn't until the 20th century, later on, 1993, that the first DMT and treatment came about for treatment of MS. It was previously a very disabling condition, and it continues to be a very chronic illness. But over time, we've been able to make a lot of progress together in understanding the disease better and making sure that we have better treatments since we first started. So back in 1993, and we started with our first medicines of interference. And then glutamate came in 96 as well. And these were just injectables that were very often for people to do, and there's still, some people that remain on these therapies now. Later on, it came in a more effective therapy, and we'll discuss what that means itself. But natalizumab came into the market around 2004, and that was like a pretty big deal at that time to control very active patients. And it wasn't until 2010, so not too long ago, where fingolimod was introduced as an oral therapy. So that was a turning point for treatment to find out other oral therapies for MS. And over time, there were a couple more therapies developed that we'll dive into. And then we realized that basically, MS can be controlled from multiple ways, and IV therapies were introduced that were a little bit less frequent and more effective than other therapies, like adalimumab, ocrelizumab, ofatumumab, and blituximab over the last 10 years, have become a lot more popular in controlling this disease for reasons that we'll discuss again. And a couple of other oral therapies in the recent years have come about as well, and a very unique one in 2019, cladribine. So as you can see, there's a lot of different medicines that have been presented to us. So it's very challenging as you're navigating a journey with the patient with a new diagnosis or a chronic diagnosis and switching therapies, it's hard to know what therapies will be best for that specific patient. So we hope that this learning activity can help us decide that together. Next slide. So we'll start with the review of low and moderate disease-modifying therapies. And this is from a small review of mechanism of actions. We won't dive in yet on each of the medicines on this first part. But again, in the 1990s, interference came in, and that was an injectable. It was the mechanism at that point proposed that it was linked to the different pathway that alters the way that the immune system and the anti-proliferate genes responds. And the idea was to reduce migration of lymphocytes across the blood-brain barrier. So it's not a direct mechanism to the CNS pathway or to the brain tissue, but it just basically reduces the external migration of lymphocytes across that blood-brain barrier. Around the same time, latinomate acetate came in, and it's thought to be related to the activation of the innate and the adaptive immune system. It's an amino acid, and it was shifting the immune system basically of the patient to be into a more protective immunity. And again, this is not acting in the central nervous system, but it's a way to modulate the immune system around it. Then in 2012, and came in teriflunomide. It was an oral therapy. It is a daily therapy, and it's thought to inhibit the mitochondria from pyrimidine synthesis and enzymes. A lot of different reduction of lymphocytes, again, in the circulation, and indirectly controlling that inflammation towards the central nervous system. This will have a lot of different side effects that will of the mitochondria being involved, but we'll dive into that later on. And lastly, on this slide, dimethyl fumarate. It's a medication, again, that had come twice a day dosing, and it modulates different levels in the T cells, and it's thought to activate antioxidants gene as well. So it functions very different than the other medicines to control MS as well. But again, all of this kind of just in the T cell department, and then we'll see how that shifts this over the mechanism of action in the next medicines. Next slide. So over time, there was a new, about 2010, another oral therapy was introduced as the first time, fingolimod, which is, again, the first oral treatment for people with MS, and it's a class of categories that are called S1Ps. There's a subtype 1 receptor of S1P that is expressed on the cell surface of lymphocytes. And at this time, it's known that it was playing a major role in how MS affects the central nervous system and the peripheral of the nervous system as well. So it's pretty involved. And S1P receptors, as you can depict from this table, there's different categories, different types of S1P. So subtype 1 is the one that we think is more involved. It's present on lymphocytes, in neurons. It's also present on AV nodes, part of the heart and conduction system of the heart rate, and also in the smooth muscle. So it wasn't very specific, but it showed to play a big role on the lymphocytes. And we'll understand why that is important on the side effect profile as well. Throughout following years, fingolimod wasn't the only one that was an S1P, and there were other medications that came as well. So the most that we're still prescribing now are siponimod, ozanimod, and those again are oral therapies. And each of them may have a little bit more interaction on the other types of S1Ps, like receptor 2, 3, and 4 are not affected by siponimod and ozanimod, and that's important in kind of the way that we monitor for side effects and why that indication can be slightly different of what to do after we start patients on these medicines. But understanding the pathophysiology, knowing that S1P receptors are present in other organs like the smooth muscles, AV nodes of the heart, can help us understand why the monitoring is different for each of them. Next slide. So switching gears a little bit to high efficacy therapy. This is a study through clinical trials, and there's no head-to-head study to make us compare between them, but it has been through different markers that clinical trials have been able to study that where they prevent relapses or no new MRI activity has been found on patients, or it's just slowing the disease progression as well. From what we know so far, can you go back, please? Sorry. From what we know so far is that like the neurons get damaged since the beginning stages of early MS. And it may precede even before the first attack of a patient or the clinical symptoms start presenting of the patient, the neurons are already damaged. So the dot after multiple studies is that medications that are highly effective include ofatumumab, ocrelizumab, natalizumab, alemtuzumab, and cladribine are superior to preventing MS relapses and preventing new MRI activity and disease progression. And the thought is that early treatment with high efficacy therapy may actually enhance the long-term progression and outcomes and minimize neuronal damage for patients starting in the early stages. So when we refer to high efficacy therapy, those are the therapies that we are talking about. Next slide. So as further evidence of the importance of early high efficacy therapy in MS patients, this study is from ocrelizumab, OPERA 1 and 2, where it basically had 2-year comparative study of ocrelizumab to an interferon, so it wasn't a placebo, and that showed slowing progression for patients. And at year 2, patients were switched over to be on ocrelizumab after interferon, basically. So everybody became on ocrelizumab. And what the line that depicts is basically over time, what's the accumulation of disability for these patients. And as you can see in baseline, they start at a pretty even stage of disease. And over time, the ocrelizumab, which is depicted in the bottom part, actually remains at the lower level. And people who were on interferon initially for those 2 years have an increased slope at the beginning for those 2 years compared to ocrelizumab and progress more, and they never able to catch up afterwards, despite them being on ocrelizumab. So it's thought that people who start on interferon, again, never catch up to those switch to ocrelizumab after 2 years, therefore starting higher efficacy early on. It's very, very important. And the actual, just from the picture itself, about 60% patients are less likely to have disability compared to other patients as well. So again, just one of the first studies that shows that high efficacy therapy is really important to prevent long-term disability for patients. Next slide. This is another emphasis study. It came from a registry of MS patients, over 2,700 patients. It's an Italian registry, so it's a lot of different demographics than in the US. But again, it followed patients for about 10 years, and it had patients who were without any therapy prior to starting high efficacy therapy. So that was their first disease modifying therapy. And compared to other patients who were started on some sort of therapy of lower efficacy, and then after 12 months or a year, they were switched to a higher efficacy therapy. So on the graph, EDSS score is something that we use to measure. It's expanded disability status scale using clinical trials, and it measures disability in patients. The scores can range from 8 to 10 and can depict how much disability patients have at that moment. So if you follow along that red line, that starts kind of in, both of them start at the same baseline again, and it's early intensive treatment depicted, meaning high efficacy therapy. That line does go up slightly, but always remains below the 3 mark compared to the other orange line at top, which shows patients that have been on that escalation approach, which means that they were started in the lower efficacy therapy and then move on to the higher efficacy therapy later on. And you see that they're able to, again, catch up with each other, and the average score, goes up to almost 3.5 versus 2.5 for patients. And to put it in perspective, a patient 3 and lower or 2.5 or so is only having very minimal mild disability symptoms at that point compared to the other one that may have more moderate issues. So again, emphasizing that high efficacy therapy is important to start from the beginning. Next slide. So to review a couple of those medications that are high efficacy, again, of the mechanism of action quick here. So natalizumab is an IV monoclonal antibody against the alpha A4 integrin. It prevents lymphocytes to pass across the blood-brain barrier. So it's a very effective way to shut down that inflammation acutely. It's a great drug to use in some patients, but it will come with this risk later on that we'll discuss again. Alemtuzumab is another IV therapy, monoclonal antibody against CD52, which is expressed on T cells and B cells. And it works through the peripheral lymphocytes via two mechanisms that our immune system has. One called CDC, or complement-dependent cytotoxicity, which relies on the complement system to activate and lyse the target that is against. And a DCC, which is an antibody-dependent cellular cytotoxicity, which basically involves the immune system. Like we have something called NK cells, or natural killer cells, that recognize these antibody-coded cells and then directly kills them. So there's two ways that this medicine works, basically. And cladribine is a nucleoside, it's an oral therapy. And again, it works very unique that inhibits DNA synthesis and DNA chain termination as well, particularly in the lymphocytes and monocytes. And I will review kind of what implicates that for monitoring in the future. The most commonly prescribed medications right now for highly effective therapy is B-cell therapy. B cells are something that is part, again, of our immune system. CD20 is expressed in B cells that are mature and in memory B cells. So the early and the late maturations, the stages of these B cells are not depleted. And that's important because that means that our humoral immune memory is preserved. We're not wiping away completely our immune system, which is modulating kind of how it reacts based on that specific receptor. And anti-CD20 monoclonal antibodies, that's basically B-cell therapies, are rituximab, ocrelizumab, ofatumumab, and obinutuzumab. And each of them are a little bit unique to the other. Some of them are more, have a different molecule or made differently with chimeric parts, like compared to other ones. And the receptor of CD20, as you can see depicted on the picture, binds a little bit different to each of them. So they're all kind of similar in the same category, but they do have a slight differences, so that can implicate of how the dosing is given or what side effects might appear from them as well. Next slide. So people with MS, because of all these immune therapies available, are less likely to experience relapses and less disability compared to people that are not on immune therapy. Again, the conventional previous approach of a step escalation, that you start low efficacy medicine, and then if they fail that, then you add a higher efficacy therapy. We don't think it's the way that we are treating MS patients now anymore, as we know that starting highly efficacious medication from the beginning is actually more helpful for patients. And overall, when you look at the immune therapy, the frequency of relapses by patients decrease a lot, the disability accrual also, but very day-to-day application of this is that the need for a walking aid, whether it's a cane or a walker, is actually decreased by close to 70% when you start highly efficacious medicine from the beginning. But we do know that access to these highly effective therapies are still challenging in our practice for multiple barriers and issues and insurance and challenges. And just to kind of add a point in there that there's still a lot of ethnic differences of treatment access for patients with MS. There's a study from Latinos and Hispanics that are less likely to be on any immunotherapy, whether low or high efficacy, on up to a third less, and also or high efficacy therapy as well. They're less likely to be present on access. Next slide. So switching focus now to discuss kind of our next learning topic from the program from today. After presenting all these medicines, it's really important to have that shared decision-making, a conversation with your patient, so that way you can pick out the best plan for them. Shared decision-making is kind of an idea where we ensure that the patient treatment goals matches our priorities as clinicians to keep them safe as well. And then we optimize the compliance and the long-term disease kind of outcome for the patient. Our role as clinicians is to help the patient become informed and develop a really personal a relationship with them and provide guidance based on our medical knowledge. And it's important to have the studies that have been done about the medicine so we can have time to answer their questions, to provide guidance about the risks and benefits, and understanding that we facilitate the patient's involvement too and create that safe environment for them. Slide. So this picture here depicts the 4 steps kind of shared decision-making in a clinical encounter. So we start with kind of like a team talk approach where I, as the physician, will explain to my patient the different choices that we have available to treat. And then again, present kind of the option talk of like the pros and cons of each medicine, doing something, not doing something, treating, not treating, and side effects for each. And then we weighed the options against the patient's preference. So we created a choice environment where the patient feels involved. And then again, based on the presented options. And at the end, we come up with that decision together where we incorporate the treatment preference and eventually pick a treatment choice. And that does take time, understandably, but it is an important conversation so that way they feel comfortable with what they start on and not, which makes them more likely to maintain on treatment long term. So in practice, when we surveyed different physicians, about 400, and about MS patients, about 700, this was a study from 6 different areas of the world where we look at patients in 2020 and 2021. And about less than a third of our patients were actually involved in their decision-making about the treatment. So so that's very, very low for, again, not applying this shared decision capacity. So patients who were actually involved in their decision-making with the patient, with the clinician to pick a treatment plan, were actually showed that the symptoms improve, including less fatigue. They felt more cognitively improved, as well as just the overall quality of life as was depicted as better when they were involved. Next slide. So again, some of the barriers to apply this shared decision-making can be very challenging in a clinical setting. That this misconception of how treatment of MS is, or the clinician bias can be involved, or just the time constraint. Insurance can play a big role of what access we get to medicine, unfortunately. The lack of knowledge, if we're not familiar with the medicine, we may not present that medicine to our patients. And understanding the role of the patient and the clinician as well, it's important. If you add on cognitive disabilities and mental health related illnesses, that can complicate kind of how you approach patients as well, because you may not feel comfortable that they know what they are deciding for themselves. So some of the things that we can do as physicians is to encourage our patients to share what's important for them and their goal each time. And our job is to offer guidance to them for the treatment and make sure that we provide unbiased opinion of what we present, but with all the facts that they need. Time is a luxury in clinic, obviously. So having a set time, maybe a couple of appointments back to back, if possible, to have the time to discuss with patients, delegate other time or other appointments to other advanced practitioners or supportive clinical staff for patients as well to educate or ask questions and ensure that you have a clear communication regarding expectations from insurance, timeline of when to start these DMTs, as well as just understanding where the patient has some adherence issues or challenges that may become a problem afterwards to maintain a healthy kind of lifestyle as well. And this last part here, basically, we want to emphasize that we create a personal relationship with our patient under this model of shared decision making, so that we can ensure that the patient has the clarity regarding the treatment expectation, adherence to medication, side effects profile understanding, so they can report back to us the risks of doing or not doing something, as well as the monitoring and the follow-up needed. And we think that by having this environment created, it will improve the medication compliance, which will be very, very beneficial for patients, for clinicians as well. So that way we don't get that phone call that a patient is having a relapse and have to be to the hospital, steroids right away. But it also will reduce the cost from the payer standpoint with decreased hospitalizations, your visits for the patient. And overall, as a society, we know that patients with MS tend to go earlier on in disability and not work full time sometimes. So it creates, but keeping them on highly effective therapy becomes an improvement for our productivity as a society as well.
Thank you so much, Dr. Andino. I actually, it's really important to highlight how much things have changed for us, right? Like we've gone from, treatments that it was phenomenal when those first treatments came about, but these days we really have changed. I mean, our practice of MS has changed so fundamentally with those high efficacy treatment. And I thank you for highlighting how the benefits are not just for patients, they're for us as clinicians, they're for payers, they're for society. And that's really so important. I wanted to ask you, before we go to Dr. Tardo, I really wanted to ask you maybe one quick question, because I know that shared decision-making is difficult. It's difficult because of time, and, sometimes we have quick clinic visits. Do you use any kind of, decision aids, to help your patients be informed about treatment? Are there, special things that you give them to review the treatment? I know I have my own preferences, but I was wondering what you do, if there are resources that you could share.
Yeah, so I think it's important to set a time aside, first of all, just the luxury of time again, just to go over everything. But I think I have utilized a lot, even just from its own pharma companies. Like they have their nurse that line that it is accessible for patients to call in and just tell me everything about this drug that I need to know because my doctor is thinking of putting that in. And some patients want to know all the details, how the trial was done, how everything. So for those high-level patients, that might be really helpful. I have utilized other resource patients that are willing to talk about their experience with the medicine with them as well, just so that they know firsthand what to expect during that infusion. Or if it's an injection, I bring them into the clinic so that the way we do it together. And that kind of eases that kind of anxiety towards the treatment. There's some other aids through other organizations that present medications in a non-biased way. So I usually refer them to that.
Like I the same way I use putting a plug for
Mhm.
the MSAA Ultimate
Yeah.
Treatment Guide. This is a
Yeah.
web-based decision aid that is unbiased.
Mhm.
That is also really good. And I just tell patients, just look up the MS Ultimate Treatment Guide, and that can help. So also some others share on the chat, they have an MS pharmacist that can
Yeah.
meet with patient. I think it's really interesting to see how your whole team can be involved in shaping, this relationship with the patient that is so critical to them being healthy, trusting in their medication, trusting in you, and keeping them on the medication long term so that they live their best lives. So thank you
Exactly.
so much, Dr. Andino. I think with this, we're gonna pass the mic over to Dr. Tardo, who, a lot of shared decision making is also talking about safety monitoring. It's hard. So maybe you can help walk us through, these important conversations. Thank you.
Yeah, thanks, Leora. Welcome everyone. So let's shift gears and we're going to kind of jump into more of the monitoring and potential need to swap treatments, which kind of goes hand in hand, as Leora said, with shared decision making. And so first, let's just do a quick overview, which I know Dr. Andino kind of already did this, so we won't spend too much time on this, just into the specific DMT categories. And typically we break these down into low, moderate, and high efficacy. So for low efficacy, these are your interferons, glatiramer, teriflunomide, and fumarates. Between the moderate and high, there's a debate. Some people like to put the S1P receptor modulators in the high category, but for the purpose of tonight, we'll keep them separate. We won't get into that argument. And so for the S1P receptors, I generally put them in the moderate efficacy, although they work great. And these include fingolimod, ezetimibe, saponimod, and ponesimod. And for the high efficacy, we have our B-cell depleters, which are ocrelizumab, ofatumumab, and ublituximab, a mouthful, natalizumab, cladribine, and alemtuzumab. Next slide. And so for each of these categories, I'm going to kind of go over the basic safety monitoring, which is very much in line with the kind of the prescribing packet drug insert for these medications. And I'm going to kind of fly through that because I want to touch more on some special considerations for each of these class of medications that I think are really important and really are the take-home message, because this is very easy information in terms of just the routine monitoring. And so for the low efficacy, it's pretty straightforward. For the interferons, you want to make sure you're checking thyroid. We do a depression screening at all of our visits for MS patients, but you need to at least be doing this yearly because this class of medication has been associated with depression. Again, really something you should be doing more than once a year. I mean, it's important to talk about this all the time, and we could do a whole talk on depression and MS. And then CBC with diff. Glatiramer, it's the lucky one. No real monitoring required for this one. Teriflunomide, the big thing here is your LFTs. Early on, very frequent, monthly, and then you can space it once they get beyond that 6-month mark. And then for the fumarates, it's CBC with diff. And the big thing here that you're watching for is lymphopenia. And so if patients on the fumarates develop lymphopenia, typically less than 600, this is something that would require a treatment swap. And we can talk about that more towards the end of the talk, but that's the big thing. So for the moderate efficacy, again, these are the S1P receptor modulators, and there are quite a few now on the market. The monitoring for these in terms of pre-labs and monitoring once on drug kind of varies for each of the drugs. The big ones are CBC with diff, CMP, VZV, and EKG. And then you'll see that I've got some asterisks beside some of the other things that are required. And so the CYP genotype specifically is for saponimod, and depending on patient-specific genotype, the dosing may vary, or they may not even be a candidate for this medication. And then OCTs is something that I like to talk about. My colleague, Dr. Squina, loves OCTs. But in our practice, we do this for all of this class of medication, but most of the newer medications actually were able to get this off of their label based on their clinical data. But honestly, I think it's something we should be monitoring, and I'll talk about it more later when I get into some special considerations. And then it's not a pre-lab, but some of these medications, specifically fingolimod, requires a first dose monitoring related to bradycardia, which again, I'll highlight a little bit more. And then in terms of monitoring, it's very straightforward. Again, the big caveat being OCTs. And at our center, we recommend this be done yearly on our patients. Early on, we do it more frequently, but in general, we like at least a yearly one after early on monitoring. Next slide. And so now I'm going to kind of jump into some special considerations with the S1P receptor modulators. The side effect profile of this class of medications is mainly based on the different selectivity for the different S1P receptor subtypes that Diana already nicely highlighted. These receptor subtypes lead to distinct adverse events. And really, first dose bradycardia is probably the most notable one and the one that people probably recognize the most. And it's really associated mostly with fingolimod. And this is where that first dose monitoring comes into play. And this is because there are not shared, but the receptors on the heart as well. And so patients can experience with their first dose pretty profound bradycardia. And so because of this, with fingolimod specifically, patients require first dose monitoring, meaning that when they take their very first dose of the medication, they are monitored for a period of time to ensure that they don't develop bradycardia. And if they do, they're not a candidate for the medication. The newer agents don't necessarily require this unless a patient has a pre-existing cardiac condition. But something important to remember with those medications as well. Next slide. The next one I want to highlight is lymphopenia. And really, if you think about how the drug works, this is expected. These drugs keep the lymphocytes in the lymph node and cause lymphocyte sequestration. But because of this, whenever you check a patient's blood count, specifically with differential, you're going to see lymphopenia. And so what I've highlighted here, and this is from each package insert for each respective medication, is the absolute lymphocyte count nadir for each of these medications. And it's important to note that there's really no correlation between infections and the degree of lymphopenia. So this can be really scary in practice if you're not used to seeing this. You have a patient on these medications and you're monitoring their CBC with diff and their lymphocyte count comes back at 400. And so I would urge you not to panic. A lot of times this just confirms they're taking their medications. If I have a patient on this class of medications and they're not lymphopenic, it makes me actually question if they're taking it. And so in general, this is not something we get too worried about. Leora and I were actually talking before we started. We each kind of have a number in our mind that we start to get nervous about. And so for both of us, it's 250, 200 to 250 is kind of where we start to get a little bit nervous. And that's in the clinical trials too, the number that they also kind of used as a cutoff. But again, no real correlation. That being said, if I have a patient who has a lymphocyte count of 400 and they're having repeated infections, that may be a reason to swap them, which again, we can talk about again later. Next slide. The next one is opportunistic infections. And so these are rare, but it's important to keep in the back of your mind because it happens. And first up is the herpes viruses. And so this includes VZV and HSV. And so what I've done is I've pulled the data from the various phase 3 clinical trials to show you these numbers. And again, it's low, but it's something that you should counsel your patients on because it's something that we see in clinical practice. If you prescribe this enough, you're going to have a patient on this class of medications who's going to get shingles or have oral herpes outbreak. And so it's just something to be aware of so you're not shocked when it happens. Next. The next one that I think is probably forgotten about the most is cryptococcal infections. And so this is a fungal infection, and it can be both a cutaneous infection or a CNS infection. And it is extremely rare, but it can have devastating consequences for patients if there is CNS involvement. And so I always counsel my S1P receptor modulator patients that, if they develop new persistent headaches, so not like their typical migraine or their tension headache, but a new unrelenting headache or an atypical rash, this is something that we need to know. And this is something that needs to be acted on quickly. We've actually had 2 cases of CNS crypto in the last 9 months at our own center after not seeing it for like 5 years. And so it's something to be on your radar. And so I like to highlight this for my trainees as well, because it's something that we often forget about because we never see crypto anymore, but we do. And then next is PML. Extremely rare with this class of medications, but we have to talk about it. And you'll see that, the numbers vary significantly from the older fingolimod to the newer agents. So the data is reassuring. The numbers are small overall. We may see this change over time, but I don't anticipate that we'll see high numbers like we see with natalizumab, which we'll talk about later. The next is macular edema. And so if you don't know what macular edema is, it's painless swelling that occurs in the central part of the retina, which can lead to blurred vision. This is actually a picture of an OCT depicting the various levels, and you could see the swelling. And so this is where the OCT comes into play, because many times this is painless, and sometimes patients may not even report blurry vision. And so this is where that monitoring comes into play, because if you see this, you should stop the medication, and it's usually reversible. Some special considerations for this class of medication, specifically with regards to macular edema, is that if a patient has underlying uveitis or diabetes, this probably isn't the best class of medications for them, unless you just have no options, because they're already higher risk for eye complications, such as this one. Next slide. And lastly, for the S1P receptor modulators, I want to discuss rebound disease activity. And so this is a phenomena that occurs whenever patients stop S1P receptor modulators. It's well described with fingolimod. Again, it's been on the market the longest and likely why we have more data. And what we typically see is that when patients discontinue drug, whether it's, they lost insurance and discontinued drug, or it's we discontinued their drug for some reason or another, they can develop severe disease reactivation and have severe exacerbations. And a lot of times these are higher than their pre-treatment disease level activity. And so this varies based on the S1P receptor modulator and really is best described with fingolimod. Again, it's been on the market the longest. And with fingolimod, it specifically tends to occur within the 2 to 4 month period after stopping drug. Again, there's less data on the newer agents, but it's something that you need to be aware of. And it's also important to realize that some of the newer agents have different half-lives. And so it may happen at different time variables for each drug. And so if you're planning to swap drugs, a lot of these may not require a washout. Or if you are doing a washout for some reason or another, you should have a plan in place on how to bridge these patients to prevent this phenomena from happening. Next slide. And so next up is the high efficacy medications. And so we've got our B-cell depleters, we've got natalizumab, and we've got cladribine. Again, this is very much in line with the package inserts for these medications, and it shows you the pre-labs as well as the ongoing monitoring. One thing to notice here is that among our high efficacy drugs, they work great, but they all work very different. And so our B-cell depleters cause sustained, continuous, targeted immunosuppression towards a specific cell line, but it is more overarching in terms of the immune system. Natalizumab is very organ specific, and then cladribine is very broad, but it's very brief. And so these work very different. In terms of the specific pre-labs or monitoring with the B-cell depleters, you'll notice that, sometimes we don't necessarily check Hep B in the quantiferin looking for TB after the initial year. However, if you have high-risk populations, it's important to continue to check this. And so in some of my patients, I do still check this yearly. And I've been shocked to find patients over time that will convert to a positive quant or things like that. And then for natalizumab, a special caveat for the JC virus, once a patient's been on drug for longer than 2 years, it may be worth changing this to less than 6 months in terms of your monitoring. And then with cladribine, the special point on the monitoring is that it's really important that for their second year, their lymphocytes need to be above 800 before they can ever take year 2. And so special considerations, if they have prolonged lymphopenia, need to be taken into account. Next slide. And so again, similar to what I did with the S1P receptor modulators, we'll talk about some special considerations. Big thing here, we're causing some immunosuppression, so infections. Infusion reactions is a huge one to counsel patients on. So patients often will experience a reaction during their infusion. And I like to tell them this is not an anaphylactic reaction. This is actually the drug working. It can feel and be described numerous different ways by patients. And so I encourage my patients to speak up, because a lot of times infusion centers have protocols in place to slow the infusion down. Pre-meds or more post-meds can be given to get rid of this. And then TB and Hep B reactivation. Next. The next important one is hypogammaglobulinemia, which is a mouthful as well. And so here I'm showing the data for ocrelizumab and ofatumumab from phase 3 clinical trials. And so with ocrelizumab, the clinical trial was OPERA. And if you look at this, what you see is that over time, serum IgG levels did decrease in a time-dependent fashion. On the other side, we have ofatumumab. Interestingly, in the clinical trial for ofatumumab, they didn't observe a decrease in IgG, and this may be in part to how the clinical trial was designed, but they didn't note it. However, they did note that mean IgM levels decreased over time. However, most patients still remained above the lower limit of normal. Next slide. And so, as I mentioned, in OPERA specifically, with ocrelizumab, there was a time-dependent reduction in IgG levels. And so this was a 2021 study by Hauser, looking at the association between hypogammaglobulinemia, again, that is such a mouthful, and infections. And what they found was that it was associated with an increased risk, specifically as it dropped, patients were at higher risk to have infections compared to those patients who didn't drop. And so something important to remember. And so if you remember back to the monitoring, we recommend, or it is recommended, that you check these levels yearly. Patients often ask me, well, I'm low, what do I do about it? And really, you know, if a patient is low and not having infections, I don't tend to do anything about it. But if they're low and they are having infections, then it may be a reason that it's time to discuss a treatment swab. Next slide. Probably the most important special consideration with B-cell depleters that I get asked about often is breast cancer risk. And so what I've done is listed the specific cases from the phase 3 clinical trials. And can you click one more time? And so you'll see the numbers. And so initially when ocrelizumab came out, there were 6 total cases. In the other B-cell depleters, and I threw in an NMO drug on here as well, just for fun, they were really, really low. But with ocrelizumab, there was initially some concern because of the signal. But what's really reassuring is that now we have longer kind of post-clinical trial, post-marketing data. The 7-year data is really in line with the general population risk. And so I know initially when this first came out, at least in our practice, some of us were very cautious if there was a family history or things like that. But now I think it's really helpful that we have this data and you can reassure patients that the data looks great. And so, you know, big thing is get your mammogram yearly because early detection is key. And for patients who are appropriate ages should get a mammogram before they ever start the drug. But this has been helpful in terms of counseling patients because this was a fear, I think, when it specifically when ocrelizumab first rolled on the market. Next slide. And so next up is natalizumab. Special considerations here is PML. I'm sure most of you know what this is. And so this is related to reactivation of the JC virus, which is a ubiquitous virus. 2/3 of the population have been exposed. But when you go on drugs that decrease the body's ability to find it, it can reactivate. And so with monitoring here, it's really important that you check the JC virus. Really, the risk comes after 2 years in JC positive patients. And this is a nice table from Continuum. And what you can see is that the jump really occurred after 24 months in patients who had an index value above 1.6. And that's really where the jump occurred. However, once a patient hits 2 years, because that's when that increase tends to happen, I personally tend to reduce the frequency between my monitoring just because I want to have this on my radar. Next slide. Also have to consider with natalizumab withdrawal and rebound, so very similar to fingolimod. When you stop natalizumab, patients can have severe rebound or disease reactivation. The activity is typically greater than pre-treatment disease activity. Typically, this is going to occur within 2 to 6 months of stopping drug. And so it's very important that if you're taking someone off of natalizumab, that you put them on another highly efficacious medication or you have a plan in place. So one thing we'll do sometimes is monthly steroid bridges to get them through this window. And this is especially important in pregnant women because we've seen rebound in pregnant patients as well who have come off drug for pregnancy. Next slide. Cladribine's up next. And so this is from Clarity. This was the phase 3 clinical trial for cladribine. If you look at this, really the biggest difference between placebo and treatment arm was lymphopenia, which again, expected based on the mechanism of action that we've already kind of covered early on in the talk. And you'll also see that there was a slightly higher number of infections and subsequent correlation demonstrated that the lowest lymphocyte count was inversely related to a higher number of infections. And so there was a correlation there. And then I've highlighted neoplasms because again, this was something that when it came out caused a little bit of pause. But if you'll go to the next slide, I'd like to highlight that there's really reassuring data now to counsel patients with. And so if what they did was essentially they pulled all of the phase 3 data, some of the post-marketing data as well, and compared it to what's called the GloboCan registry, which is a cancer kind of tracking and prediction type thing. And what they found was that despite a slightly higher risk in the clinical trials, it's really in line with the general population. Cladribine still has a warning against this, and it's very important to counsel patients and should be avoided in patients who have cancer. But in terms of just when you talk to patients, it's important to give them this information, because I think when they hear cancer risk or they see the black box warning, it can really turn patients off. But the data is extremely reassuring and continues to be reassuring, that it's really kind of in line with what we'd expect in the general population. Next slide. So now we're going to shift gears quickly because I know we're running out of time, in terms of disease monitoring. So what do you do when you have a patient with MS and they're on DMT? The most easy one is imaging. And so we typically recommend getting a new baseline MRI 3 to 6 months after DMT initiation. And this is kind of our new baseline. And from that point forward, we shouldn't see new changes. And then typically in our practice, we get MRIs every year thereafter, although some people will space them after, 5-10 years to every other year, just depending on the situation or financial circumstances of a patient. We like to get OCT, like I said. This is important for us to track. We may not necessarily use it as a reason to swap drug, but it's something that we track in our patients. There's also clinical monitoring. So these are your visits with patients. Generally, we like to check in at least twice a year with our patients. However, there's some who are super stable, who only want to see us once a year. And I will generally say, okay, you only have to see me once a year because you're getting your labs on time and all of those things. And so other clinical things are the EDSS, which in clinical practice probably isn't as done as much as it does in clinical trials. And you can track the relapse rate. You can do timed 25-foot walks. You can do some 9-hole peg testing and some single-digit modality testing, which are really clinical trial markers, but it's good sometimes to be able to track over time if patients are having a decline. It's not necessarily feasible all the time because time is of the essence, as we have already mentioned today, in terms of these clinical visits. But if you can incorporate these are really good things to track over time. And then probably the hottest thing on the market right now is biomarkers, which I think they're still sorting out a lot here, but serum neurofilament light is a good one. And there's been some validated data here, and it's a good thing to track if insurance covers it. So you can check it, when someone starts drug and monitor it, right? And ideally we'd see it drop and stay low. We like in practice to draw it on our some of my patients who are coming off of drug as just a baseline. So if they're having issues, I can repeat it and see if it's raised again. GFAP, more to come on this. I don't think there's enough information yet, but probably also going to be something that over time can be tracked. I know they're doing it in clinical trials, but clinically, this is not something that I'm personally tracking at this moment. Next slide. And so when do we make a change? The obvious is disease progression, whether it is a relapse, a clinical relapse, or an MRI change. But there's some more nuanced things that may make me make a change as well. And a big one is patient preference. And so if a patient is having intolerable side effects, that's a reason to change. We have too many medications on the market to keep patients on drug that they do not like or tolerate. And the same can be said on impact on lifestyle. I have young patients who cannot remember to take 2 pills a day. And so if you've got a BID medication, it's probably not the best medication for them. Or they hate shots, or they hate IVs. And so it's important to consider this in that shared decision making that we had talked about earlier, because this alone can really impact compliance. Cost of medication is also important, and can be a hassle for everyone, but important to consider. The next thing is pregnancy planning. There could be a whole 2-hour talk on pregnancy planning in MS, which we don't have time for. But the big thing here is you want to make sure that patients have stable disease before they get pregnant, if possible. There are certain DMTs that have to be stopped within specified time frames for pregnancy. And so that may be a reason that you need to change. And then it's also to consider postpartum planning, because you may or may not go back on DMT or change DMT based on breastfeeding preference of patients. And then finally, the aging patient. This is a hot topic and also sometimes a difficult conversation.
We have a question on that in the chat, so save some of those thoughts for the Q&A, Lauren.
Okay, this is my last little blurb. And so, patients often really like their MS medications, and they're kind of safety blankets, and I get it. And so this can be a difficult conversation. And so There's always a conversation of do we stop drug or do we swap, meaning de-escalate. And so sometimes I'll de-escalate patients from a high efficacy to a low efficacy for safety reasons. And a lot of this comes down to a risk benefit conversation. And I often say, at what point does our risk and benefit shift to where there's more risk? And I use that illustration often with my patients to convince them to trial off of medication or swap. And then there's this big theme of immunosenescence. And do we really need disease modifying therapy once we hit a certain point? And I think that there's something to be said there with our aging patients. And so it's important to talk about that and bring this up with patients.
Awesome. Thank you so much, Lauren. And I bring back Kathleen Costello, the interim president of the CMSC, to chat with us and discuss those questions we have in the Q&A box.
Yes, thanks very much. And thank you all for your great presentations. Very, very informative. The first question is really to the point you were just making, Dr. Tardo, and that was about discontinuing ocrelizumab after the age of 65. Do you use an age cutoff? If not directly in your mind, are you thinking about when to have that conversation relative to immunosenescence, for example?
Yeah, it's a great question. And I don't know that, there's a specific age cutoff. It's really patient dependent, right? If I have a patient who has late onset MS, it's not someone who, when they hit 55, 60, I'm going to be pushing this conversation. But if I've had a patient who's had MS since age 30 and they're now 60, and they've got documented 20 years of disease stability, at least 5 or 10 on their class of medication, that's generally when I'm going to start to have that conversation. I'm going to push the conversation a little bit more if they're having infections or side effects, because at that point, that risk-benefit ratio really shifts. And so I tend to push the conversation more in those patients than my patients who are stable, not having any complications. And one thing I always spin it as, it's a trial. I'm not taking away DMT forever. If your body proves to us that you need to go back on, we can go back on. And so that's generally how I approach that.
Yeah, that's a great segue to, sorry.
Yeah, no, just a quick add, it's important also to add that, part of these conversation about DMT in older age must also often be accompanied by a conversation about, prevention and preventive care. It's really important to emphasize that, particularly on patients who are on high efficacy therapies, vaccination. Are we treating their bladder issues appropriately to prevent bladder infections? So it's a multi-layered conversation where we need to do everything that we can for these patients to prevent complications at the same time that we continue to monitor, their disease. So, those are always very interesting conversations. And as Dr. Tardo said, very nuanced and very personalized conversations.
So regarding that last question about discontinuing, if you were to discontinue a treatment for whatever reason, particularly maybe someone wants to stop or they're older, how often would you be monitoring them, both with MRI and a clinical visit, just to ensure that there's not reactivation of disease?
So I can take that one. I think that, first it's like you have to, just like Lauren highlighted, I mean, I like monitoring my patients, every 6 months. When you tell somebody we're stopping ocrelizumab, for example, well, they may have low B cells for a very long time after that. So we're not really off of the medication right the moment we say that we discontinue it in some cases. I think that really, certainly if the medications we're stopping is, for example, an S1P modulator or natalizumab, when we're stopping this, even in older age, it's important to really have a follow-up, I would say within 3 months, because the risk of rebound can exist even in older age with those medications, and we need to be aware of that. Stopping ocrelizumab, the follow-up can be much later, again, because longer-acting medication. I think it's important because, as Dr. Tardo said, sometimes we're not taking the medication away. If there's a need, if there's progression, if there's relapses, we definitely need to be able to make those decisions. So I like to follow, with the medication that have a risk of rebound, definitely follow early. Otherwise, at least every 6 months and have that conversation. MRIs yearly. We also do biomarkers. We've been using the MS disease activity test by Octave Bio, and I like monitoring that as well every 6 months in patients who discontinue to have an extra layer of information about how patients are doing. So I don't know if anybody else has another opinion.
I agree completely with all of that.
Same.
Excellent. Thank you. Thank you. I think we have time for one more. We're a little over, but I'd like to get this question in. And we didn't talk a whole lot about alemtuzumab. And the question is, what are your thoughts about alemtuzumab? And when would you consider this medication versus others? And I'd like a little bit from each of you on how you use this medication.
I think my answer will be short because I have probably the least experience with that drug myself. But it's been kind of like a third layer approach to the patients that we've had on it once they fail other ones. But again, they probably have more experience than I do.
Yeah, I have little experience as well, just because where I trained, we didn't use it that often. I left it off, and I realized I left it off today actually when I was going through my slides, and I think I left it off because I don't actually use it that much, because there's a lot of risk and monitoring that goes into it. One of the big things, again, we didn't have a slide on this, but one of the big things that you can see with alemtuzumab is early B cell reactivation. And so patients can have a really bad relapse after their treatment course. And so I saw a lot of that in my fellowship. And so I think it might have scared me away a little bit. And so I tend to only recommend it if none of these other agents are good options personally.
Yeah, I think for me it's the same thing. I've used Lemtrada. I'm probably the seniorest of the three. So I have used alemtuzumab and I have seen complications that I do not wish to see. So I tend to really reserve it for patients who have failed about everything else. I think that there are ways to maybe target even aggressive disease in treatment naive patients that, is not alemtuzumab. It's really important to educate also patients that treatment with alemtuzumab is not a cure. I know that, some people tended to say, well, this is like a stem cell transplant and we're curing patients from MS. No, we're not, even using medications that are just as strong as alemtuzumab. So yeah, I would agree with my colleagues, probably kind of a last resort type of medication with a lot of education into, the potential risk of, redeveloping disease activity afterwards.
Thank you. Thank you all. And I think that we're about 3 minutes over. There are a few other questions that I personally had, but I can table those to another time. And I think we should probably wrap it up so people can get back to their evening. Laura?
Well, I want to thank everybody for joining us tonight in the audience. So thank you so much for being here with us. More importantly, I'd like to thank our esteemed panel that are with us tonight. That was a very informative presentation, and it will be archived on our website in case anyone is interested in watching it again. But with that, what I'd like to do is just share my screen one last time and let you know that if you'd like to connect with us, connect with Can Do MS, you can do so on social media. We do have one more webinar in this series. It is going to be case study presentations. It will be next Wednesday at the same time. So please join us. We would love to have you for the third webinar in this series. With that, I'd like to say thank you again. Have a good evening, everybody. And we hope to see you next week.